Hey, it's Nick Fogelson from Northwest Endometriosis and Pelvic Surgery. Common question I get from patients is whether or not we do any kind of diagnostic surgery prior to doing a treatment kind of surgery. Like, do we go and look and then find out, okay, you have endo, then we come back and operate again some other time? And the answer is no. In fact, doing that would be dumb. What we do is if I'm going to operate on somebody, I'm going to fix them. I'm going to do everything I can do to fix them at that first surgery. That's the whole reason to operate. And for anybody to do a surgery that's purely diagnostic, if they don't really have the ability to do anything about it, is certainly a very suboptimal surgery. And so we don't do just strictly diagnostic laparoscopies. We'll do a diagnostic laparoscopy followed by doing whatever it is that I can do that's going to help the patient's problem. But we're going to try to be very thorough. We're going to look for not just endometriosis. We're going to look for hernias. We're going to look for gallbladder issues. We're going to look at the diaphragms. We're going to look all kinds of things that I might find that are potentially causing pain. We're going to look and try to address it. And if we have the patient's consent, we may do things that are different. Like if they had an inguinal pain and I find an inguinal hernia, if I have their consent, I'll get a general surgeon to come in and fix it. So they woke up. I don't just have them wake up and say, hey, you got this problem, go get it fixed. They woke up, patient will wake up with it having been fixed. As long as I have patient's permission to do things that may be a little bit different than we expected. And part of that is that we have a really good multidisciplinary team. So I have access to urologists and general surgeons and hernia surgeons and bowel surgeons and everything that I need so that I can try to address whatever may come up in surgery. And we do that. I've had patients come where we think it's going to be a relatively simple excision surgery, and sure enough, they got a big lesion in their colon and they need to have a major bowel resection. In most practices, that's a quit surgery and come back another day, but in our practice, it's very, very likely that we're going to be able to arrange to have that surgery done under the same anesthetic, so the patient wakes up with what needs to be done having been done. And that's why it's really important that I counsel all of our patients kind of on the kinds of things that we might do and make sure that we have permission to do, make sure we understand what we have permission to do and say, you know what, you can know exactly what we're going to do at the risk of maybe having to have another surgery, or you can leave open the idea that we might do something different than what we fully expected ahead of time, but you're just going to get it all done in one surgery. And medically, it's always better to do it in one surgery. Like doing a hysterectomy and then coming back and removing endo, then coming back and doing a bowel resection later is not as good of a surgery as just doing it all at once. It's not this is not 1/2 + 1/2 = 1. It's you end up with more inflammation, more scarring. It's just really good to do it all at once. So no diagnostic laparoscopies. We do thorough treating therapeutic surgery to the greatest extent that we can in every case that we can. And having that team of people is part of why we're able to do that. I do notice a lot of surgeons talking, particularly in Europe, I think in socialized healthcare systems too, a lot of concern to figure out exactly what is going to be needed at surgery, and I think that's because the resources required for the surgery may need a lot of coordination, so they really want to make sure they're not surprised. In my practice, I like to know what we're getting into, but I also know that if it ends up being different than what I thought, we're very likely we're going to be able to deal with it at that moment. So we're fortunate to have a team like that. It's part of, we help create that, but we're also fortunate to have really supportive colleagues too. So if I can help, feel free to give us a call. If you need a scope, we will scope you and do, whatever is needed, we will do that at that moment so that you leave having invested your time, invested, the pain of surgery, and then whatever money's involved, that we're going to get you the best value you can get, just the best, best outcome with the minimal amount of intervention. Thanks for listening. Let us know if we can help.